Hi class. Okay, now we're going to go over chapter 13 regarding pain, temperature, sleep, and sensory function. But this first 15-minute block is just going to be on pain. So in this crazy picture that you are looking at is a concept map of pain. This tells the nurse exactly what their brain is going through when someone comes in with pain. We need to know what the characteristics are, the location, the duration, what people say, what number they're rating this pain scale on, what makes it better, what makes it worse, etc. These type of things is what pain means. But we need to go into detail regarding the pathophysiology of pain and all that before we get into this, which you will cover in your nursing classes. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage, or at least that's defined by the International Association for the Study of Pain. I hope most people find it an unpleasant sensory and that it's not a pleasant one, because that's usually what brings us in, is that we are hurting, we don't feel good, and we need to do something about it, whether it's moving the body, going to the doctor, etc. McAfee described pain or defined pain as it is whatever the experiencing person says it is, existing whenever he says it does. So meaning that we cannot say just because someone looks like they're not in pain that we can't say they're not in pain. It is whatever they're experiencing and whatever they say it is. We have to believe them when they say they are in pain. Now, of course, there's different types of theories regarding pain. Specificity pain is been argued that the body has a separate sensory system for perceiving pain, just as it does for hearing and vision. And this system contains its own special receptors for detecting pain stimuli, its own peripheral nerves and pathways to the brain, and its own area of the brain for processing pain signals. Hence, it is specific. And again, that's just what the theory is out there. The other theory that we talk about a lot in nursing is the gate control theory. This was proposed by Melzack. He said that the theory of pain has stimulated considerable interest and debate, which is true, and has certainly been a vastly improvement on the early theories of pain. Pretty much what's going on in this theory is that the pain stimulation is carried by small, slow fibers that enter the dorsal horn of the spinal cord. Then other cells transmit the impulses from the spinal cord up to the brain. These fibers are called T cells. The T cells can be located in a specific area of the spinal cord known as the substantia gelatinosa. These fibers can have an impact on the smaller fibers that carry the pain stimulation. In some cases, they can inhibit the communication of stimulation, while in other cases, they can allow stimulation to be communicated into the central nervous system. So, for example, large fibers can prohibit the impulses from the small fibers from ever communicating with the brain. In this way, the large fibers create a hypothetical gate that can open or close the system to pain stimulation. According to the theory, the gate can sometimes be overwhelmed by a large number of small activated fibers. In other words, the greater the level of pain stimulation, the less adequate the gate is able to block the communication of this information. So if you've ever fallen down and hurt yourself when you were a little kid and your mother comes and she rubs the site, or even you rub your site, you're kind of like you hit your elbow. Let's say, for example, you hit your elbow on the table. You have pain. You rub it because it's an automatic reflex to go where the pain is, and you rub it. As you're rubbing it, the pain diminishes, meaning that you're closing the gate to the brain and saying that you have pain. One of the theories also back in the day was, your mom when you were little would probably kiss the boo-boo. Well, she's kissing the pain away and closing those gates so that your brain is not sensing any pain. Otherwise, if there's no stimulation in that area, your brain will constantly think that there is pain, hence why we call it the gate control, because it either opens for pain or closes when you're not in any pain. Now, there's also this theory for pattern. But they propose that there is no separate system for perceiving pain, and the receptors for pain are shared with other senses, such as touch. So, according to this theory, people feel pain when certain patterns of neural activity occur, such as when appropriate types of activity reach excessive high levels in the brain. These patterns occur only when intense stimulation, because strong and mild stimuli of the same sense modality produce different patterns of neural activity. But that's just that theory, as well as the neural matrix theory represents this plasticity of the brain and provides this holistic, integrated dynamic view of pain. We do know that we have certain definitions. Nociceptors, they kind of are the receptors of letting us know when we have pain and not. Nociception is just defined as the perception of pain. But with our nociceptors, we have our A delta fibers, which kind of are myelinated, and they travel fast. They let us know if we're in any acute or sharp pain. So those are myelinated, so they slip right up to the brain pretty quickly. Unmyelinated are your slower and deeper pain, and these are your C fiber, our polymodal fibers. And these kind of cause that more burning or cramping type of feeling that you will have regarding pain. So our neuroanatomy of pain, also we have transduction, which is the activation of those nociceptors, the receptors, the transmission, of course, of sending the signals that we have pain, and then the perception, whether it's sensory, motivational, or cognitive, for our pain. So here's your dorsal horn, and you can see how the fibers connect and go through and signal to the brain when we're having pain. Neuromodulators are located in the pathways of your nervous system. They are triggered by tissue injury or inflammation. And substance P, glutamate, and somatostatins are those that are excitatory neuromodulations. And then we also have our inhibitory neuromodulations, such as our GABAs, serotonins, norepinephrines, endorphins, etc., to inhibit any pain. So if we're in any pain, we have our substance P that is activated, and then our body can actually inhibit that pain with our GABA and endorphins to help us make us feel better. So they kind of balance each other out during homeostasis. But if we have an imbalance in one of those, then that's when you'll see either more pain or not able to feel pain. So again, endorphins, we know we have different endorphins that makes us feel good, our natural body response for when we do have not feeling well. So we have our delta receptors. Those function is for analgesia. They can cause an antidepressant effect, and with our delta receptors. Our kappa receptors, again, same thing, analgesia, sedation, and can kind of give us that dysphoria feeling, and they inhibit the release of antidiuretic hormones. The mu receptors are these that are more concerning, especially when you talk about pain medications, because it can depress our respiratory system. Clinical depression, a description of pain that you may come across. Of course, people define what is the pain threshold. We'll ask our patients. It's the point at which a stimulus is perceived as pain. For example, imagine someone is tapping on your arm and taps progressively hard. Eventually, that tapping will become hard enough to hurt, and this is when you have reached your pain threshold. Perceptual dominance is pain at one location may it cause an increase in the threshold in another location. Existence of pain at example, if your arm hurts but then someone steps on your toe, your arm doesn't hurt anymore, right? So your toe hurts. So that's sometimes what can happen in the perceptual dominance. Also regarding pain tolerance, that is the duration of time or the intensity of pain that a person will endure before initiation of pain responses, meaning it's the amount of pain that someone can withstand before he or she suffers from an emotional or physical breakdown, which really takes them into the hospital. We also have acute pain. Acute pain is actually our protective mechanism. It lets us know that we are having pain now and we need to do something. Again, either move the body part, go get help, something. It's an acute. Something's wrong and we need to get help. Usually when patients have this acute pain, they are having the heart increases, the blood pressure increases, their body temperature increases, they become more, the sweat increases, so they become diaphoretic, dilated pupils. Again, it's the fight or flight system occurring, what's happening during acute pain. Acute somatic pain, it arises from your connective tissue, muscle, bone, and skin areas. Acute visceral is more in your internal organs, in the abdomen. It's harder to localize or define where it's at, but we know it's in that general vicinity. So visceral is more deeper and somatic is more higher level or more closer to the skin. Referred pain, some patients can have referred pain depending on what's going on with the patient, meaning that pain is present in an area removed or distanced from its point of origin, such as, for example, when patients come in with heart attacks, a lot of times it's not just the heart that hurts, but they may have jaw pain, left arm pain. Those type of things may be occurring and it's referred to a different location, such as in these pictures here. Someone may even have a liver pain and it's radiating up into the right shoulder. So those things can occur. So when patients come in with pain, we need to find out where the location is so we can see if it's an actual pain in that location or if it's been referred to from another area. Chronic pain is persistent or intermittent. It doesn't have to be constant, but yet it's chronic, meaning that it lasts longer than 3 to 6 months. Response patterns vary. Most of the time the body's behavior or they don't show any physical signs. Really, the body has become kind of used to it, and so it balances out during this stage. So you will not see the fight or flight response in chronic pain. So it makes it harder to diagnose if the patient, what kind of pain they really are experiencing. Your sickle cell patients, if they're not in a crisis mode, may have this chronic pain. Cancer patients, they can have chronic pain. They are get their body, eventually it starts off with acute, but then the longer they have the cancer, the longer their manifestations do not appear. Neuropathic pain is damage to the nerves. It's usually chronic as well, such as peripheral diabetic neuropathy, maybe even some phantom limb pain, meaning that someone had an amputation. When there is pain in that area, they amputate and they still feel that the body part is still there causing pain, and so they think that their leg is still there when it's not, but they still feel the pain. Young children with pain, they are actually present during birth. They found that back in the day they used to not circumcise boys because they didn't think they felt pain. Now they realize pain is there, and so they do use some numbing agents. As we get older, our pain threshold increases because we can tolerate more pain. But we can develop more peripheral neuropathy so that we end up with more chronic pain issues too, and our skin can thicken as we age until we get really old and then the skin gets thin. So I'm going to stop the video here and then we will continue with body temperature for the next part 2.